Hi everyone, my name is Brittany Chambers. I'm the Associate Director of Education at the Center to Advance Palliative Care. At a medical convention in 1966, Dr. Martin Luther King Jr. declared, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." 54 years later, that declaration still rings true. The COVID-19 pandemic has thrusted a spotlight on the many inequities that currently exist in our society. We've seen that certain communities, because of race, geography, their socioeconomic status, or complex care needs, has led them to have higher risk of poor outcomes. As a Black woman living in the United States, I am personally committed and interested in trying to address the many inequities that we see, specifically in the palliative care and public health sphere. I really believe that addressing the consequences of health inequities, as well as the system that allow them to flourish, is the responsibility and will require the participation of every single person living in this country. Palliative care teams are particularly at an advantage for helping to address this problem. They are among the leaders who really promote the importance of trust and really preserving the dignity of care for seriously ill patients throughout the country. Palliative care is actually grounded in health equity principles because the goal really is to maximize quality of life for people with serious illness, regardless of their age, the stage of illness, their gender, race, or ethnicity. And so what I would like to just message is that palliative care's core functions have not changed in the context of COVID-19. Building the relationships of trust and effective communication is more vital than ever. And CAPC is committed to supporting teams and providing resources to help ensure equitable care. For the next 30 minutes, Dr. Karen Bullock will share her insights into how palliative care professionals in our community can play a role in ensuring that your patient population really has access to care that will alleviate their suffering. Dr. Bullock is the perfect person to talk about these things. She is the professor and head of social work at North Carolina State University. She has more than 25 years of clinical expertise in aging and especially in health disparities. And her research has focused primarily on social support for older adults as well as serious illness equitable care. Dr. Bullock is also a John A. Hartford Scholar, and she serves on many different national boards and committees, including the Social Work, Hospice, and Palliative Care Network. And then finally, she is a member of the National Academies of Sciences on their Serious Illness Roundtable. And so it is my pleasure to turn this over to Dr. Bullock. Thank you.
Hi everyone, I'm Karen Bullock, and I'm so glad to be with you today. I'm going to be discussing some strategies that palliative care teams and leaders can explore in terms of thinking about how to ensure that the most vulnerable members of your patient population, especially those in traditionally underserved racial and ethnic groups, have access to care that relieves suffering. What I know about CAPC is that it is dedicated to increasing the availability of quality health care for people living with a serious illness. What I learned about CAPC, I learned within my network, and my network consists of committees and coalitions that share a similar mission and/or objectives to improving access to palliative care for persons with serious illness. I have the fortune, when I'm in these spaces, to give voice to issues and concerns of people who look like me, who grew up in communities like my community, in families like my family, who oftentimes, when receiving care, are receiving this care from providers who have no idea about their cultural values, norms, beliefs, and experiences. So my network is truly my net worth to my community and to people whose voices need to be heard around racial equity in healthcare systems. So I have the opportunity to represent and reflect the narratives of populations of underrepresented patients in the settings that I'm in. And so I'm going to start by using my own narrative to set the tone for talking about health equity and racial equity in palliative care. When I was a doctoral student at Boston University, my mom was living in North Carolina, and she was diagnosed with metastatic lung cancer. She was living with inadequate health insurance, low literacy, a lifetime of no access to preventative care, distrust for the healthcare system, and thus she invited me along on her journey to what would become my passion for advocating for and giving voice to health equity and eliminating health inequities. I'm sure most of you have seen this image before. I think it's an excellent depiction of why it's important for us to not feel that we have to treat all patients the same. This image here represents the need for us to meet our patients where they are to ensure that there is access to care, that the receipt of care is equitable, and that the quality of care is equitable. Racial bias is normalized by a plethora of historic, cultural, and institutional practices and policies that routinely advantage one group while disadvantaging another group. Our healthcare institutions are a microcosm of the larger society. And so if we are going to achieve equity in palliative care, we're going to have to begin to address these routine advantages and disadvantages that leave traditionally underserved racial groups excluded from equitable care. But where do we begin the conversation? How comfortable are we talking about ethnocentrism and structural racism, assimilation and white supremacy, to name a few? We could go on, prejudice, marginalization. If we're going to tackle this issue of racial inequity in palliative care, we have got to get more comfortable with saying the words out loud. We have to get more comfortable with engaging in conversations in the workplace, in our care settings, with our colleagues, with our family members, with our friends. Because I know that this is an audience of highly skilled, highly competent, highly educated, and prepared practitioners. And addressing racial equity should be no different. We should feel comfortable, we should feel confident, and we should feel confident and competent. Yet, so many of us are very uncomfortable having these conversations. Palliative care is that care that, as we all know, is provided by a specially trained team of physicians, nurses, social workers, and other specialists, and it is appropriate at any age across all stages. So why is it that so many people of color, racial and ethnic groups, believe that this care is not for them? How is it that we, as palliative care providers, team leaders, administrators, how is it that we can utilize our skill sets, our knowledge, our positions of power and authority to create opportunities for groups of individuals and families and communities who currently believe that palliative care is not for them? How do we invite them into conversations and understanding? How do we invite our colleagues into conversations and understanding around racial equity and palliative care? We talk quite a bit about evidence-based frameworks and approaches that we can incorporate into our practices, but if we're not comfortable having the conversations among our colleagues and our teams, how can we best utilize frameworks to guide us? We need to think about these cultural inventories that are available to us, cultural competency measures, etc., that help us to move along in the areas of addressing our own implicit and explicit bias. And we can link them to performance reviews and practices. However, we must have the conversations about the tough issues like racism, again, microaggressions, systemic alienation, a plethora of different terms that we are still grappling with to understand what is the place within palliative care of these concepts. And if we can identify best practices for hiring and training diverse teams as well as leaders, we can begin to move the needle. Accountability is essential. Individuals engaging in professional development have the opportunity to address these issues on an interpersonal level, on an individual level, and even on a structural level. Action steps begin with each of us, and we all have a role to play in our healthcare systems to dismantle barriers. So what will you do? Will you be able to address any effects of racism that may be present in your palliative care settings? What about other forms of oppression and racial injustices? Are you able to identify them and have conversations with your team members? Are you able to explore human rights violations? We like to think in healthcare settings that these concepts don't exist. We'd like to think that everyone is treated equally. Yet, if we begin to drill down further and come to understand what does systemic racism look like and how is it playing out in palliative care organizations and across care teams, we will begin to recognize and identify areas in which we need to continue to explore, to confront, and to take action steps. And again, these action steps bring in the whole person. This diagram shows the intersectionality of the whole person in our workspaces as palliative care providers. There are action steps that we can take as individuals that will lead to interpersonal and impact institutional and structural barriers. One such example that we can address structurally is assessment. How do we as professionals engage in our practices in terms of matrices and measures for appropriate practice, ethical practice? Not all people have the same needs, not all patients have the same needs, nor experience the same barriers. A formal examination of our practices within our organization will enable us to reveal patterns of various subtle racial inequities in palliative care, and the cultural inventories that we incorporate will enable us as individuals to assess our own biases, our conscious bias and our unconscious bias. However, if we remain in very comfortable settings where we don't have the opportunities to experience biases, how can we be sure that we have the capacity to address those that manifest in our environment if we're comfortable in our settings, if we are never the other, if we are never the one who is on the outside of the privilege and the opportunities? Can we truly give voice to these issues that we don't know personally? And I'm not suggesting that each person has to experience racism to understand that we have a role to play in eliminating it. But if we are going to identify conscious bias and unconscious bias, we need to have the context in which we can do that. This may mean that within our work environments that we have opportunities to sit down and talk about tough issues like the racism that we may be seeing or that other people are giving voice to, but perhaps we as individuals are not seeing it because we don't have the lens through which we can see those disparities. Not all people have the same lived experiences. Not all people have the same lens through which we can evaluate structural barriers. On an institutional level, there are things that each of us can do. We can advocate for, we can help to develop, and we can participate in education and training that aren't just those that are mandatory and required annually. We all have, competencies that we have to be assessed on each year, but what about going above and beyond and seeking out additional trainings and education to ensure competency around racial inequity and disparities? We can create a philosophy of racial justice care in palliative care, and we can commit to ushering in these changes as a discipline of care. On an interpersonal level, it's important for leaders to help advance racial equity. Leadership that is driven by those who have the authority and those who have the duty and responsibility to ensure that there is equity in practices need to model the behavior that we want our colleagues to see on our teams. It's imperative that those in the leadership roles and those who are decision makers are the first to give voice, are the first to lead the way. And they, in order to demonstrate this commitment, there is a responsibility and a duty on the part of the leaders to also engage in professional development. On an individual level, we think about self-awareness and assessment of our biases, as I mentioned previously. But we need to keep in mind that race relations are influenced by personal, internalized beliefs, and also the socialization in the context in which we live and thrive and work and practice. We talk quite a bit about becoming more aware of our own biases. But again, if we're of a dominant group and we're comfortable with the way in which access to resources are provided to us, can we truly know the experience of those that have been historically marginalized and excluded? So there are a number of suggestions that I would make to each person who's interested in leaving this presentation or this talk thinking about what can I do as an individual? What can I do next week or next month? And how can I begin to take tiny steps towards bringing about change? Here are some very, very basic things we can begin to talk about. How about getting to know more Black and Brown people? Now, oftentimes we use the term people of color interchangeably, but remember, I emphasize how important it is to begin to say the words that so many people feel uncomfortable uttering. But if we can refer to people by race, if we can talk about racism, we can move in the direction of beginning to understand how important it is to address these issues. Socially and personally, the vast majority of my colleagues whom I ask this question of how often are you having social and personal exchanges with Black and Brown people, the response is very rarely. We know that medicine consists of predominantly white practitioners. We know that palliative care, primarily the patient population is white. And here we are talking about racial equity. Again, if we are going to begin to see change, if we want to be change agents, we need to have conversations about racialized violence and systemic racism. Think about how many opportunities you have had to have these types of conversations. Now, someone might ask the question, what does racialized violence have to do with palliative care? Well, you may be caring for patients who've experienced racialized violence. Do you understand the impact in the communities? Oftentimes, patients who have been historically discriminated against or alienated from healthcare practices or systemically disallowed health equity are not comfortable when they must come to receive care, and especially care for a serious illness. It's one of the most vulnerable times in anyone's life, and we know this. And so if we can begin to understand the impact of these societal issues on our patients when they come into our care settings, perhaps we can develop a rapport that will move things along the continuum so that folks who have been historically excluded will begin to want and take advantage of the excellent care that we all provide. You can talk with your colleagues and friends about race and racism in healthcare. For far too long, many of us have wanted to believe that racism doesn't exist in healthcare. Healthcare is accessible by all. But I would suggest if you spend some time with your colleagues, if you create a structure for having these types of conversations in your care settings, you might reveal some dynamics that you really hadn't thought about before. I would suggest creating a structure for doing so. If you have the time, consider mentoring a person of color. Many professionals who are coming into palliative care, who may not be in palliative care, but who are in healthcare settings, who are members of these historically excluded groups, marginalized groups, need mentors. And the mentor doesn't have to be of the same race or ethnic group. It's important for us to reach across the table, to reach across the racial lines, and to support each other in a host of different ways that can make a difference in creating equity in palliative care. Also, cultivate diversity in your leadership and on your teams, among your teams. How many people of color are in leadership roles in your care settings and on your teams? Think about whether systemic racism may have played a role in the absence of diverse leaders in your care settings and on your team. And then be willing to speak up publicly about these issues, not necessarily always against, but for racial equity. You may work in a setting where you feel that all people are comfortable and you don't have issues of inequity, health inequity, or racial inequity. But even if it's not existing in your care setting, each discipline have professional organizations and learned societies that we participate in. If it's not happening in your setting, perhaps you have some nuggets of wisdom that you can share with your colleagues who are in other settings where it is an issue and a concern that they want to address. So speaking up publicly and speaking in numbers can be powerful. So again, I thank you for the opportunity to begin a conversation about achieving equity in palliative care. And I'll leave you with a video link here. I would encourage you, when you have time, to watch it. It's only about 4 minutes, but it's an excellent example of systemic racism. And I think it can help to advance our efforts to begin the conversations around racial equity in palliative care. Thank you for this opportunity to speak on this very important topic today. CAPC will make the YouTube video available on its website.